Good afternoon. Welcome back to UCSF Department of Medicine Grand Rounds. I'm Bob Wachter, Chair of the Department of Medicine. Welcome, as always, to our live audience here at UCSF and our department throughout the UCSF Health system. As usual, we will post this video at about 7 o'clock tonight Pacific on YouTube, and I will tweet out the address. We're now up to about 1.3 million views for this series. The ground rules for our live audience are here. If you have questions, type them into the Q&A box. My colleague Quinny Chang is moderating them, and we'll try to get to as many as we can. Put your Zoom window in full screen mode. To paraphrase Dickens, this continues to be the worst of times, but the promise of the best of times is tantalizingly close. We're probably a week or two away from having two remarkably effective vaccines available for use, and yet 2,800 Americans died of COVID yesterday, nearly 2 a minute. The cumulative death toll of COVID is now the equivalent of the population of Orlando, Florida. In a week or two, we will be up to the city of Pittsburgh. So it is staggering what's going on, and we're seeing surges everywhere in the country, including here in the Bay Area. Today, after a brief overview of the current state of the epidemic by George Rutherford, we're going to look at two issues that are top of mind for many people in the current phase of the pandemic: the brutally difficult decisions about the schools and how vaccines will actually be distributed when they become available. So let me briefly do introductions of our four speakers. The first up will be George Rutherford, who you know by now if you've been following the series. He's been educating us and much of the state and the country on the shape of the pandemic for the better part of a year. He's a professor in our Department of Epidemiology and Biostatistics, medical director of UCSF's Prevention and Public Health Group, and his research focuses on epidemiology and prevention of infections, which this is. After hearing from George, we'll turn our attention to the schools. Of all the what do we do about this questions in COVID, I have to say that I find the issues of the schools the most vexing, with powerful and often contradictory arguments always advanced with passion. What's increasingly clear is that luckily kids tend to do relatively well clinically, and at least young ones don't spread the virus quite as much as adults, and yet it's awfully hard to keep schools open in the midst of a surge. To help us think about these issues, we're really pleased to have Emily Oster, who's professor of economics at Brown University, join us. Emily studies health and development economics. During the pandemic, she's emerged as one of the leading experts in the country on these issues surrounding the schools, both through her research and frequent appearances in the media and articles in publications such as the New York Times and the Atlantic. She's author of a few books, including Crib Sheet, very cleverly named, a data-driven guide to better, more relaxed parenting from birth to preschool. And hard to do more relaxed parenting this year, but we will hear about how from Emily in a few minutes. So after Emily's presentation, George will return and we'll have a discussion about the schools with Emily and George. Then at about 12:40, we will toggle to vaccines. Who would have thought that a month ago that we would be talking about how vaccines will get distributed, when a month ago we didn't even know for sure that there would be vaccines that worked. But we're now probably in the next week or two poised for the FDA to approve one or more of the vaccines, and we're going to have to sort out the questions of who gets them, when, and how to do the distribution. Those questions are complex and are multi-layered. The CDC has already begun to weigh in on the staging in terms of who goes first, who goes second. You probably have heard about that. But much of the decision-making actually falls to states, and much of the practical implementation and some decision-making will fall to individual institutions that are given shipments of vaccine and charged with distributing them and doing some prioritization within the guidelines set by the state and by the CDC. So it is really complicated. And we're going to hear from two experts who are grappling with these issues, even as we speak, who are going to tell us how they are thinking about these complex issues of distribution. The first is Erica Pan, who is one of our own. She's a professor of pediatric infectious diseases at UCSF, but her job now is as acting state health officer for the state of California, where I imagine much of her time is being spent thinking about the distribution of vaccines at the state level. She's also deputy director for the Center of Infectious Diseases and state epidemiologist. Prior to joining the California Department of Public Health, she'd been the health officer and director of the Division of Communicable Disease Control and Prevention for Alameda County. So that will be thinking about this from the state perspective, and then a whole bunch of vaccine is going to arrive at the UCSF Health system when we will then turn to Desi Kotis, who is UCSF Health's Chief Pharmacy Executive and Associate Dean for the UCSF School of Pharmacy. Desi is responsible for development and implementation of a comprehensive strategic plan for UCSF Health, Department of Pharmaceutical Services. But I'm guessing that for the next month or two, most of her job will be all vaccine all the time, every day, 24 hours a day, trying to figure this out and make it all work. So Erica and Desi will give brief presentations, and then we'll have a discussion with the two of them, and we'll bring back George Rutherford for that as well. We will go till about 1:15 or 1:20 or so. So with that preamble done, let us turn things over to George, who's going to take us through the state of the pandemic.
Thanks, Bob. It's a pleasure to be here with everyone again, and I look forward to hearing everyone speak. The cases in the United States were far, far, far from out of the woods. You can see that here from the upper right-hand panel, we're deeply into a third phase. This little dip down that you see here on the far right may or may not be real. It could easily be an artifact of the long Thanksgiving weekend with people not getting tested. Cases are continuing to rise explosively around the country. The only three states that aren't surging are Hawaii, Maine, and Vermont. There may or may not be some modest decrease in cases in the upper Midwest, but in the largest number of cases over the past 7 days, from per capita standpoint, are in South Dakota, Minnesota, Wyoming, Nebraska, now Rhode Island. And in absolute case numbers, California has now overtaken Texas, Illinois, Florida, and Ohio. And there have been more than 90 deaths per day in Illinois, Texas, Michigan, and Pennsylvania. And you can see we're not out of the increasing numbers of deaths either. Can I have the next one, please? Here you get an idea of where this is going on. You kind of clearly can see the upper Midwest, Great Plains here, but also the Southwest, and New Mexico's actually about 6th on that list. You can see the whole kind of West Texas is filling in as well. Here's Rhode Island over here, another problem area. Here in California, this is Lassen County, this is Kings County. This is probably a function of the ongoing outbreak at Avenal State Prison. The next one, please. We have reached more than 100,000 people hospitalized for COVID-19 in the United States yesterday. And we have a 7-day moving average of 94,000 people being hospitalized. And you can see that it's far greater, almost twice as high as it was during the first and second waves of the epidemic. The next one, please. Here in California, we've had almost 1.3 million cases. We added 18,000 new cases yesterday. The 7-day average is more than 14,000 a day, which means that there have been 100,000 cases, newly diagnosed cases in California over the last 7 days. There have been almost 19,500 deaths with a 7-day moving average of 67 deaths per day. Unfortunately, these are predominantly in Southern California, but we are not spared. If you look at where the counties are with the greatest numbers of cases, and this is not per capita, but it's totals. So Los Angeles, San Diego, San Bernardino, Orange, Riverside, and then we get up to some of the other, to Northern California, Santa Clara, Sacramento, Kern, which is in the lower San Joaquin Valley, Ventura, which is right next to, it's between Los Angeles and Santa Barbara. They're having an upswing, and then Alameda here in the East Bay. The next one, please. If you look by county in the Bay Area, we've had almost 157,000 cases and added 2,000 cases yesterday. We have had almost 2,000 deaths and had an additional unfortunate 11 deaths yesterday. If you look here at the absolute numbers of cases, Santa Clara went up by 1,274 cases over last week. And then this is in, so you have Alameda, Sonoma, which has had a really hard time getting things back in the box, Contra Costa, and then San Mateo in the city. One bright spot is that Napa has had 130 fewer cases, and Solano's gone down a little bit. This is looking at cases per 100,000 per day. Remember, 7 is the magic number here in terms of the tiers. This is just the most recent thing. So only one of the counties here, which is Marin, is outside of the highest tier, the purple tier. And the R-naughts are the basic effective reproductive numbers are all well in excess of 1. And the lowest one is still 1.12, which is way too much. And there's no downward inflection here. The proportion of positives ranges from 1.8 in Marin and San Francisco up to a high of 6.8% in Solano. So these numbers would all suggest we're locked into a very explosive phase of transmission. The next one, please. So in response to this, California is imposing new restrictions. I have the governor's press conference on in my other ear, but I haven't heard the buzz yet. So hopefully Dr. Pan will tell us. Statewide, there are 30.2 cases per 100,000 with 7.3% test positivity on average. So that's well above the Bay Area. The effective reproductive number, however, is lower at 1.07. 99% of the population is living in counties in the highest purple tier. There's a statewide curfew in purple tier counties from 10 p.m. to 5 a.m. And the additional measures may be imposed in the most affected counties. And that has, for those of you of my generation, you'll do a double take, but it's been called the deep purple tier. The next one, please. And that's because we remember the Deep Purple band, such hits as I can't remember. The next one, please. California overall is at the 7.3%. You can see how it's been going up since early November. And we're also above where we were even in the summer surge in terms of total beds, with 8,500 people hospitalized as of yesterday. And we've also pushed up on ICU beds, and there are 1,810 intensive care beds available statewide. This, by the way, takes out the neonatal intensive care beds. The next one, please. This is the slide the governor showed on Monday, which has pushed all the alarm bells. This is looking at current ICU bed usage. This was as of Monday. The projected proportion of ICU beds that would be occupied by Christmas Eve and the date that we would cross ICU capacity. You can see that statewide, the concern is that you're going to hit this be over capacity by December 24th with Southern California, where again, 2/3 of the population lives, at 107% of capacity on December 24th. The San Joaquin Valley from Sacramento South at 120%. And then by Northern California, they mean except Greater Sacramento and except the Bay Area. So that'll be pretty high. That's going to be way over capacity as well. I think we've already started to see transports from other counties into the UCSF hospital. In response to this, what do we do? Well, the real answer is primary prevention to prevent people from getting infected in the first place, which means better social distancing and mask mandates. And I think that's what we're going to be hearing from Dr. Pan, not to guess, but. And then the secondary prevention is about increasing capacity. This is about vaccinating healthcare workers. So we're not having 300 people in quarantine or out of work, as has happened in a large hospital in Fresno County. And we also have to increase bed space, which is the temporary hospitals, the hospital ship, all those kinds of things have to be on the table. The next one, please. But there's good news along with the bad news. So let's do the next one, please. So the first bit of good news is that here's a country, France, which has managed to make its epidemic drop, and it dropped precipitously. What did they do? They've done a lockdown since late November. People are working from home, unless they work in shops where that have remained open. You need an exemption certificate, essentially a hall pass, to leave your home. So the police will send you back if you don't have one of these certificates, and so that it really cuts down on traffic. The schools have remained open. Bars, restaurants, cinemas, theaters, and gymnasia are closed. There's no internal travel within France allowed, so you can't cross from department to department. And there's screening required at the border. And they actually have this in English if you want to read some more about it. It's quite interesting what they've been able to do. And the last one, please. The other bit of good news is that while we were dreading a large influenza season that would multiply the bed capacity problem hugely, what we know is that, however, now is that there's been a mild to almost non-existent influenza season in the Southern Hemisphere. And to date in California, we've had very, very low levels of influenza with a single death, 0.2% lab positive outbreaks, and Northern California Kaiser, which is one of the surveillance systems, has only had 10 admits for influenza and no detection of novel influenza strains. So I'll stop there, and I look forward to answering questions. Thank you.
Great. Thank you, George. And Erica will discuss a little bit at the beginning of her talk what the state is announcing, even as we speak. So thank you. We'll hold on for that for about 20 minutes or so. So let us turn to Emily and turn to the issue of the schools and how she is thinking about that extremely complicated problem. So let us bring Emily on.
Great, thank you so much. So thank you for having me. I look forward to talking a little bit about this problem. I want to sort of set the stage to talk about, I think, why this is so complicated and why it's been so complicated to learn about. Early on, I think that we kind of very quickly learned that kids were a relatively low risk group. And then we started to get some evidence from other countries that maybe schools and childcare settings could be safe. But I think the problem, the big sort of issue that we have run into is that even if kids themselves are not that likely to be affected, and even if schools in Europe have operated safely, the US is really different. Schools are not just kids. And so one of the things I often say is, like, it's not Lord of the Flies. Like, there are teachers in schools, and a lot of what we have learned is really about how are we going to think about protecting teachers. And so I got into this because I am interested in data on kids, and I'm interested in data on kids. And I realized as schools started to open, and actually the first schools in the US in the COVID era opened in basically August, and they opened in places with very high positivity rates. So if you sort of remember early on, Georgia, Indiana were the places that were opening. And yet it seemed like we had no systematic way to collect data on what was happening with kids in schools, and in particular on not just how many cases are there, but how many kids are in school. So we would see anecdotal news reports that would say, well, there's one case in this school, but it was difficult to know, is the school have 100 kids, does the school have 10 kids, does the school have 1,000 kids? And so we embarked on a little bit of a project to try to sort of put together some public data on this. So I'm going to tell you a little bit about what we've done and maybe a little bit about what I think we've learned. So next slide, please. So the project I'm going to talk about is called the COVID-19 School Response Dashboard, and a little bit of our motivation is here. But to be a bit more concrete, what we did in this project was reach out first to individual schools and districts and ask them, will you participate in this? Will you tell us how many kids you have in school, what kind of mitigation strategies you're undertaking, how many staff you have? And then we'll come back and follow up with you every other week and ask you how many COVID cases have you had in your school population, and then we'll post that publicly. So that's where we started, and it has a lot of issues with who is going to opt in and so on. But we've actually managed to augment the data with, at least in a couple of states, with a universe of data there, which has both grown the sample size, but also let us be a little bit more representative about what we can say. And the effort sort of continues to try to collect these more of this kind of sort of systematic data. And I see this as really having sort of three goals. One is just to provide some generalized overview of risks. I think when we were coming into this, there was a question of, are schools going to be super spreaders? Are schools going to be the locus of very large outbreaks? That was kind of the first question we wanted to think about, and we thought we just did not have the data to answer. The second question is, how is this varying with community rates? So to what extent does it matter how much your community is spread? Is there some level at which you kind of have to shut down, or is there some level at which you can't open, or sort of questions in that space? And the third thing is just the role of mitigation and opening plans. So trying to help districts and schools navigate, should I be open in different circumstances? And so I'll try to give a little bit of a sense of what I think we've learned about those, with the acknowledgement that this is still very much an ongoing sort of set of questions. Next slide, please. So this is the kind of pull of the most recent data. So in the most recent wave, we do this on these biweekly waves. So in the most recent biweekly wave, which is kind of the first half or middle part of November, we're covering about 3 million enrolled students, of which 1.5 million are in person. In the overall dashboard, there's like over all of the waves, it's like 25 million student wave enrollments. We have quoted these case rates. We've sort of gone back and forth in what's the right way to do this. You can, of course, convert them in whatever way you choose. But what we're seeing is the student case rate, and this is daily cases per 100,000 kids, is 14. So that amounts to something like one case in a school of 1,000 over a 2-week period, maybe 1.5 cases. For the staff, the case rate is 34 per 100,000. And then we've put up the matched community rate here. And the reason why this is such an important metric is that what we are asking and what we are collecting is not incidents of transmission in schools. I may come back to this at the end, but really what we are asking about is, was there someone affiliated with this school that had COVID? That is the data that is being collected. Most schools do not have sufficient contact tracing to really sort of dig into, was this spread in schools? So if we ask, what would we expect? Well, we should expect the case rate to, if there's no spread in schools, the case rate should look kind of like the community rate. And so we would sort of, one of the things we're looking out for are large deviations from the community rate. And here we're doing this sort of community rate per 100,000. If we put in something like testing positivity rate, that number would obviously be like vastly larger. It's not obvious which is exactly the right comparison. Next slide, please. So the most comprehensive data we have is from New York and Texas. So I wanted to just sort of pull that out for you. So here's the data from New York, and this is covering all schools in New York. So New York requires all schools to put in their data. And I should say this dashboard is public. You can play around with it and do things. This picture is on it. So we just pulled some of this stuff directly down from there. So what you can see is in the New York data, the rates are going up over this period as the rates in New York go up. So the gray line is the community case rate. So that's sort of rising over this period. The blue line is the student case rate, and the green line is the staff case rate. And you can see them sort of moving a little bit together. Next slide, please. We wrote about this in the Washington Post, and we actually tried to visualize a little bit more the kind of relationship between community rates and school rates. So if you look on the right, this is looking at the rates in school staff and high school students, and you're seeing those are really very similar to the community rate. So this is the 45-degree line. So you can see these are kind of really more or less right on that line. And so we're seeing staff and high school students kind of lining up with the community rates. In elementary and middle school students, we're seeing rates that are significantly lower than the community case rates. And I think that is reflecting probably not anything particular about elementary schools, but more about elementary school students being a lower risk group because younger kids are younger kids are lower risk. Next slide, please. So there's sort of two other things I wanted to highlight. So one is we also have pretty comprehensive data from Texas. And here, although we're also sort of seeing that when the community rates go up, the school rates go up, we're actually starting to see here a little bit of a difference between staff rates and student and community rates. A little bit of evidence here that maybe the staff is at higher risk than the community. Whether that reflects spread in schools, obviously beyond what we can see in our data. But as we get into these higher numbers, I think people have started to talk a little bit like about how it may be difficult to keep it may be harder to limit spread in schools in some of these sort of higher risk areas. Next slide, please. So finally, I just wanted to say sort of two things about mitigation. So one is about masking. And here we've kind of taken the data and divided it into these groups by case rate levels. So sort of lowest risk, medium risk, higher risk. And then we've separated out places where the students are masked and places where they're not. And this is, places where they require it. And what you can see is actually for the students, the differences are pretty small, but for the staff, they're really big. So the places where the students are not required to mask, which I should say is not a large sample, but it is some schools, we are seeing much higher case rates in the staff. Next slide, please. But probably also somewhat interesting, we've actually broken out a little bit the density. So looking at basically places where people are fully remote, where we actually only see information on teachers. And then schools where the in-person density, and this is like average daily in-person attendance divided by total enrollment, varies from sort of lower, middle, kind of high. And here, actually, if anything, like for students, we're seeing a little bit of evidence that the higher density places actually have lower case rates. For staff, maybe it goes a little bit the other direction. So this is something I think we need to sort of dig into a little bit more. Let me just end by saying, I think the sort of big questions, there are many big open questions here, probably the most significant one of which is what is going on inside schools. And that is something we can't see in these data. And in general, I think the data has been very limited for. We really need to understand to what extent is spread happening inside schools. And I think that not only do we need to understand that, we need to start focusing our choices about schools on what is happening inside them. And so as we have sort of started talking more about the values of reopening, a lot of the conversation has focused on the idea that, hey, we're not seeing a lot of spread in schools, but we actually don't have enough contact tracing to know as much about that as we would like. I think we're seeing a lot of evidence that that's true, and a lot of increasing evidence that elementary schools can be done safely, but exactly what that looks like and what are some of the pitfalls, that is something we need to invest more in learning. And we don't have that much time, because the sort of flip side of this is that remote learning is really not working well for a lot of kids, and we're seeing increasingly very bad signs about both learning and mental health. And so I think it's got to be a priority to figure out how we can do this safely, particularly for the youngest learners. So let me stop there.
Great, thank you, Emily. Let's bring George back. And let me start and push you a little bit on recommendations. So we got to make a choice. Do we open them or not? And we now know more than we knew 10 months ago. But I'm sure you've been asked by billions of parents and school districts and others, how do we decide what to do? And we can't just wait for more and better data. So what do you say?
I would say K-8 or K-5 for sure. I would open, and I would open it with parental choice, and with masking, allowing parents to choose, but otherwise 5 days a week. So I actually think what they have come to in New York, I think is basically the right choice, because I think that the losses we're seeing in the youngest learners are so big, and we just have not seen a lot of evidence of any big outbreaks in elementary schools. I'm a little more hesitant on high schools in particular, because I think, as we open high schools and we have sports and so on, we are seeing at least people reporting, hey, this sports team had this and so on. So I think that those groups are a little more complicated, but I think for sure K-5 and special needs kids, I would open now, and I would have open basically in any tier.
So there's no amount of COVID in a community, South Dakota today, you would say what we know about K through 5 is such that we think we should and can do school safely.
Yeah, I mean, I think that when you talk to people there, when I talk to superintendents in those places, what they tell me is like the problems they're having are with staffing, that staff are in quarantine and they have trouble staying open. So I think that's been the issue, but they're pretty clear that they don't think that they're seeing spread in the schools, even in very high prevalence areas.
George, we always forget that you're a pediatrician as well. So there you go. How do you answer the same question? What is your recommendation about what we should be doing with the schools?
I think you start pre-K, and which you didn't mention, but I'll mention it. And at least the schools I know about here in 6th grade, you stay in the same room largely. It's when you start getting them mixed up that I think gets more complicated. So I've been pretty sanguine about pre-K through 6. After that, it's kind of a crapshoot. It's clearly much more of a crapshoot in high school than middle school. But, I think that's that's kind of where I'm coming down. I mean, there are a couple of things coming down. I think that there's gathering consensus that teachers represent essential workers, so that they may be in that tier 1B for vaccination. And the second thing is that CDC has also now recommended a much shorter quarantine period, so we can get people in and out of quarantine in 7 days as opposed to 14. So that should help with some of the staffing as well.
So Erica is on patiently waiting in our green room for our next session, but she's expressed a willingness to come on and comment on this from the state perspective. So if Alyssa, if you can bring her on, we'd love to hear that. Well, there she goes. All right. Why don't you go ahead, Erica, sort of how are you guys thinking about this at the state level?
Sure. Yeah, I would happy and really an honor to get to sort of at least virtually meet Emily, because I've been following your work, and a couple of things we're working on, wanting to have some sort of dashboard for the state as well. And I just want to echo that what we are seeing of the schools that are open really, is resonating from what I'm hearing from the local health departments and local health officers on the ground as far as low transmission. And I would even, I do think with good compliance, even in high school level, I think there's a lot to be said about, limiting other extracurricular activities and other things. But I think in general, we really want to do everything we can to keep and or get our schools open in California. So anyway, so I just want to agree and echo that both what we're seeing on the ground is very little evidence of transmission in the school. Marin County happens to have really good data about student days, and they've had one case, I think, that they attributed staff to staff in the school setting, but none from kid to kid or kid to adult. And just that is a huge priority as well for us to get our schools open.
Great, thank you. Emily, you're an economist. Talk to us about what we know about the economic consequences of keeping schools closed.
Yeah, I mean, I think that we're seeing big consequences for working families, and I think that in some ways these are very gendered. So we saw early on in September there was a huge drop in labor force participation, and that was almost all women. So the labor force lost a million people, sort of saying like, I'm not interested in having a job, and 800,000 of those were women, and I think they were basically concentrated in the age group such that they would have kids at home. And I think people are just finding it basically very, very difficult to have a job and also, supervise their kids on Zoom. Although I will say at this point, I think that people are more worried about their kids than their jobs. I think that the Zoom fatigue in people's kids is really tough. And the people whose 6-year-old needs to be on Zoom for 8 hours a day, that's a really hard thing for a 6-year-old. It's a hard thing for me.
Yeah, right. I think for all of us. As you, maybe George and Eric can weigh in this as well. All right, we want to keep the schools open in an environment that's surging. It seems clear that masking is an important part of that equation. What's the role of testing in making that all work? Emily, do you want to start with that, and then love to hear from the others?
I mean, I think that testing, I think if I were to prioritize rapid testing, I would do teachers on a regular basis, because I think that will both increase confidence and trust. And also that is the highest risk group. So I might do them every week, every other week, maybe more than that if you have it. And then I would do some surveillance testing in kids, partly again for sort of reassurance, and partly because you might be able to pick up if you're starting to have an outbreak. But I think prioritizing teachers for the testing would be my number one thing. And I think it's something we really need to think about doing.
George, any comments on that?
Yeah, I think you're absolutely right. It's the Chinese models are all based on the teachers bringing it in and transmitting it to the kids. So it depends on who we're trying to address, whether it's the parents of the children or the teachers. And I think that by testing the teachers, you can address both. I also agree that we need surveillance testing, and there are all these, there are these fancy things like lot quality assurance, and you can do it. And I think that's the right way to go.
And so, Erica, how are you thinking about testing and sort of programmatically? It sounds like you and your colleagues in the state have come to believe that the schools are really important. Obviously, you thought that before, but that it's doable even in the face of something of a surge. But practically, do school districts have the resources? Do they have the expertise? Do they have the PPE? Do they have the testing? So at a state level, and I realize I'm putting you on the spot because this was not even what you're going to talk about, but go ahead. How are you guys thinking about making this actually happen? If it's one thing to be in favor of it, another to actually get a school open in the light.
Exactly. You nailed it. I mean, I think, for example, with our blueprint tiers, many schools could reopen in red, orange, and yellow, and many of them hadn't. And I think, Emily also really highlighted it's really helping teachers and staff feel comfortable. And so I think on one hand, there's that UC Berkeley model showing that actually the masking and the distancing is much more important than the testing. On the other hand, if we can make teachers feel more comfortable and just sort of demonstrate and detect cases early if we're testing often enough. And then as far as resources, we're really, I think this is our next sort of big thing to just, and we're working closely with, CDE, the Department of Education, and CTA and others. Our new statewide lab, the Valencia Branch Lab, one of our highest priorities is schools and reaching out to counties and school districts to help provide some of the testing. But, as you're alluding to, I think the logistics are really still difficult. And then in the middle of this surge, our testing capacity is getting stretched again, even though we've doubled our capacity so far in the state. But in the middle of this surge, I think it's just some of the slow testing turnaround is happening again and some of those issues. But we are really trying to put lots of resources, more PPE, testing, and just lots of education too. So I think it's really important to have this discussion here so that our medical community can continue to talk to parents in the community about this as well.
Right. Emily, as we think about the role of the teachers and sort of making the teachers more comfortable, sort of interested in your observations about teachers' unions and their role in all of this, and probably adds some degrees of complexity. And also the fact that the school world in the United States there's public schools, there's private schools, there are religious schools. Are they responding to this in different ways? Are there lessons from some of those sort of natural experiments?
Yeah, I mean, I think we've certainly seen more private and religious schools be open than district public schools, and we're certainly seeing archdioceses open in places where even in sort of like urban school districts where the district public schools are not open. I think that's proved to be a good model. It's actually some data that I would like to pull in to try to understand a bit better, how that's been going. Although my sense from talking to them is that they feel like they've been able to do this safely. It's not exactly the same population. I think that there has been resistance to opening from teachers unions. I don't think that's speaking out of school. And I think that some of that really does come down to these issues of trust and kind of wanting to feel like they will be protected, and that we are sort of not sending teachers into an environment where we're sort of abandoning them. And in general, we don't invest enough in public education. And I think that that's a sort of, there's a lingering feeling of that even prior to COVID that I think we need to clearly address as we sort of think about this problem. So, I have started to see, Randy Weingarten said the other day that I think that she sort of thinks that K8 or K5 that she's supportive of that opening. I think that's a good move. I think, we need to sort of rebuild the trust a little bit that maybe has been decayed by some of the politicization of this discussion. I think if we can do that, we can sort of move forward in a way that makes people comfortable.
I assume there's I shouldn't assume this, but maybe I'll phrase it as a question, like they say in Jeopardy. Is there an economic argument to say we should have and we should be investing in the schools, for example, let's say rapid testing or other things, because of the economics on the back end, not only on lost productivity of the kids over time if their education is harmed, but for that parental workforce? I think is it a matter of sort of the buckets are wrong, that it's clear that the economics are favorable to make a big investment, but we have these different buckets and we're not able to reconcile it.
Yeah, I mean, I think it's clear. I mean, I think Larry Summers made this point in an op-ed like very early in the pandemic that we should be spending billions and billions of dollars on testing because like actually the economic losses of, like that could be regained with that, if that was the solution, are enormous. And so I think there's sort of, you could say a similar thing about schools. Obviously spending more money on this would be good. It can be a little hard to know exactly what to, even if we had the money fire hose, like exactly where you're pointing it, I think is not totally clear. And so it's partially a money problem and partially other problems, but certainly money is, I'm an economist, money is always going to be important.
I'm not an economist, but I knew that one. George, maybe I'll give you the last word on this topic. If you take the clock back to March, what should we have done here on the schools and for the next pandemic? How do we do this differently?
You have to realize that in March, we were driven by an influenza A model. And influenza A is hugely amplified in elementary schools. And what happens to your grandparents and older people is all a function of how much transmission there is in elementary schools. And I think we acted on the data we had. I think going forward, we now have another model, which is a disease that binds to ACE2 inhibitors, of which are less prominent in younger children. And we might have gone down a different path if we'd known that at the time, but I don't think we knew that at the time. And I think it turns out, probably in retrospect, it wasn't the best decision, but at the time it was sort of the only decision based on what we knew of influenza epidemiology.
That's interesting. So we got sort of locked into a way of thinking about this and we're unable to unlock ourselves once we did. Interesting. Emily, any last words you want? I know you have to go. Any last words you want to leave us with?
No, I mean, I think I would exactly echo that. I think that, we sort of had a model and it's been really hard to shift our thinking to understand the sort of way these risks have played out in this particular disease.
Yeah. Yeah, no, it's so fascinating. I mean, the analogy to masks is very real. There's a way of thinking about this in February, and it turned out to not be right because we learned more. That's the way life goes, and we were not able to be nimble and toggle our thinking quickly enough, unfortunately. Well, thank you for spending some time with us. We're going to shift gears to distribution of vaccines, and hopefully the teachers will get them early, and that may change the dynamics here. Keep up the great work, and let's turn it over to Erica now and give you the stage. And we'll then bring George back at the end to have the discussion along with Desi. But Erica, take us through, and I know you maybe take a couple of minutes to not talk about this, but talk about what the governor is just announcing now about what's happening in California.
Sure. Yeah, thanks. I just want to, echo again, thanks for having me. It's really great to be back at UCSF, and I, trained here, and the schools issue is not only important to our entire kind of administration and myself, but as a pediatric infectious disease person, this is just a really important interest of mine. And the other quick point back to the schools and that last question that I would actually mention is that the schools actually, back to trust, closed themselves in March. They actually all closed before we did the shelter at home. I was in the Bay Area, one of the initial Bay Area sort of that did the first stay-at-home order, and the schools had closed before we did that, and we were actually still trying to look at some of these models. And again, I think it's true that we did a lot of, because of other respiratory viruses being kids being the drivers of transmission. So. But they actually closed on their own. Were not directed by sort of public health, at least. And I think having George tee up sort of the epi was perfect as far as looking at, what has happened across the world, across the country. And, we've done an amazing job in California as Californians, but we could not sort of escape our borders and just this very unwieldy virus. So we've had this surge, the worst we've seen. And what we are announcing today is that we're really worried about our ICU capacity and our hospital capacity, most importantly, our healthcare staffing, actually, but it's a little bit harder to measure healthcare staffing as far as the triggers. So we are looking at the state as regions, and George already showed you kind of one way to slice and dice our California regions. Those happen to be health officer coalition regions that we've been looking at over time, and that health officers have actually been working together on. And essentially, what we just announced is that any region where the ICU capacity is 15% or less will be put into a stay-at-home for 3 weeks. And it's going to be very similar actually to the March order, but we are keeping schools open because, again, this is our highest priority. We do have some, concerns that some schools may actually close themselves. I know that even prior to this, the San Bernardino School District said that they're not going to open again for the rest of the school year. But we really want to work closely with our teachers again and staff to provide the resources to help them feel safe. And so again, this sort of dialogue is really helpful as well. So I think we do know that we can flatten the curve. We did it in March. We have a much higher burden of disease this time around to do it. A couple other quick things about that. So the trigger again is the 15% ICU capacity. That region will go in for 3 weeks minimum. At the end of that 3 weeks, if the projections show that 4 weeks out, there's 15% or more capacity, then the county in that region can go back into our blueprint tier based on their case rate and their test positivity. So that is sort of how this will all work. And again, pretty similar with a few exceptions to what we had in March. Indoor retail will be allowed at a 20% with strict metering though, again, and some other restrictions, no food or eating. We're really trying to minimize any time anyone's indoors with other people outside their homes without a mask on. So those are some of the key differences. And again, that schools remain open, and more details will be, I'm sure, forthcoming, because I know what you want to hear about is vaccines, which is, again, the light at the end of our tunnel. We know this has been really hard for Californians to be trying to do the masking and physical distancing and staying as much as possible from others, and that this is going to be a hard time to hunker down during the holidays. But it's a good segue to really talk about vaccine planning. And as we've been starting to discuss, that vaccines are on their way. It is going to take several months, right, before we can get enough vaccine, which I'll start a good segue to talk through this. But I think if our community can stay with us and hunker down for a few weeks to really kind of just cool this virus off, which has been going straight up, as George is showing you on those graphs. So that I'll segue to the next slide. So just again, wanting to briefly talk to you about what we're doing at the state level, kind of how we're organized and how we're thinking about things. We have a vaccine task force that is comprised of our immunization experts within our own health department, emergency planners, logistics, communications, really working on external outreach. And really, first and foremost, especially given the background environment of vaccine hesitancy, the background environment of sort of the politicization and dichotomies that have been presented around sort of public health measures and vaccines, we really wanted to make sure Californians felt comfortable with the efficacy and safety of the vaccine. And we're so lucky, again, here in California to have world and nationally known experts that are already on federal committees looking at vaccine safety, many of whom are from UCSF, actually. So we developed a scientific safety review work group, and there are several, again, UCSF faculty, others from across the state. And actually, we are a multi-state work group. So there are Washington, Nevada, and Oregon have joined our scientific safety group. So we have other immunization, immunology, public health experts, again, at the local, state, and academic, who are staying on top of the vaccine candidates and trials. Again, some of them have either currently on or were previously on the ACIP work groups. And the other really important message around this work group that we want people to know is not only are we trying to get as much data and following the data all along the way, we plan for that group to meet, within 24 hours, just like ACIP is planning to meet within 24 hours of any EUA approvals. Our group will do something similar, and we really don't want this to cause any delays, but we again want to be able to use and leverage our experts in California to really reassure us at the state level in our community that the vaccines that are approved are safe and effective. And then we also, really importantly, have a community vaccine advisory committee. So this is multiple different stakeholders from a lot of different professional organizations, including teachers organizations, school nurses, other communities of color, to provide advice to us on every step of the way. We're really concerned about again, needing to make sure we have trusted messengers and that people, again, have trust in the vaccine. So the Community Vaccine Advisory Committee is the largest one, and that's a public committee. You can actually tune into it. We've had 2 meetings so far. The co-chair is our California Surgeon General, Dr. Nadine Burke-Harris. And then we have a drafting guidelines work group that is smaller, also a lot of immunization experts, others that are helping us think about these national guidelines. So you alluded to the phase 1A, 1B. So phase 1A has been now approved to be healthcare workers and also residents of skilled nursing facilities and long-term care facilities. And then we're now starting to dig into the phase 1B and essential workers and defining those. So the drafting guidelines work group is developing those, drafting them, bringing them to the community advisory committee for input. Really our three key values are safety, equity, and transparency. So trying to make sure we're incorporating all of those into everything we do. So again, when those presentations are to the community advisory committee, those are all public and recorded. And then there are notes from each of the meetings for the other things that are posted publicly. So we're working really hard as well in the background of all that to be ready to vaccinate in California once this is all available. And working closely with our local health departments and with healthcare systems. I think this is perfect to hear after I finish how UCSF is thinking about distribution within the healthcare system. And again, the communication campaign, I think, is one of our biggest challenges. Next slide. So I won't go through all of this. I know I'm short on time and we have some dense slides, but I think the most important key messages here are that, again, we're the largest state. We're chosen by CDC to do some micro-planning early on. We have a lot of infrastructure already that we've done for H1N1 in 2009, during the hepatitis A outbreaks among the homeless, our annual flu vaccines for children program. So there's a lot of infrastructure already in California at the state and local level for doing all of this planning. Next slide. And then this just gives you some numbers again of how much flu vaccine doses get distributed every year, in California, tens of millions of routine vaccines. Most of those are actually distributed in clinical settings. And local health departments are a key safety net, but give typically less than 10% of, for example, seasonal flu doses that help do some back to school campaigns and a safety net. But again, during large pandemics or outbreaks, have worked to do mass vaccination campaigns. Next slide. I think just some key lessons learned from H1N1 in 2009 that we do sometimes get direction and advisement from the federal government about what we're receiving, and then often it's slightly different when we get it. So we put out numbers to you about what's coming, the over 300,000, and we hope that is what we're getting, but it often changes. And then what also is really important for people to know, especially these first distributions, the federal government, we on the health and government side will help with the allocation and sort of assignment, but the shipment will actually go directly to vaccinators as approved by the state and local health departments. It is of course going to be a little bit more complex this time around as far as needing to have physical distancing in the setting of vaccination. And again, our public trusted messaging is really critical. And we, again, well, actually next slide, and I'll talk more about some of the other planning things. So this is kind of a nice slide to think about the different phases of what's going to be happening. So in the beginning, we're going to get this trickle, right? So in a state of 40 million, an initial shipment of over 300,000 is not very many. We have over 2 million healthcare workers alone in California. So there are going to be tough decisions that, again, are some of the guidelines around who are the highest risk healthcare workers and different criteria have all been proposed. And then each local health department will also be making some allocation decisions, and then each healthcare system will be making those decisions for those first doses that come. One common question too is, so there's this first amount of doses, and because the first two vaccines that have been approved have a 2-dose regimen. So the plan is there will be over 300,000 people vaccinated, and then the federal government is then sending the next second dose for those same people 2 to 3 weeks later. So we're going to have this trickle in again with sort of the priority populations. And then as time goes on, we'll be getting more and more vaccine, and sort of you'll see, as you see this sort of peak in larger doses available, and they'll be able to expand to outside of the essential workers. Again, some of this work is happening in the nitty-gritty level with the drafting guidelines group. And then, it'll eventually normalize back into routine vaccine strategies. Next slide. And then just, again, some of the unknowns that are making the planning difficult. We have a great infrastructure, but, not knowing until the end which vaccines will be approved, if there's going to be different efficacy in different subgroups, volume and timing, the second dose requirements, and as many of you know, some of them are 21 days apart, some are 28 days apart. Those ultra low cold storage requirements and other requirements are a real challenge, but we're doing a lot in the background. We're already pre-purchasing, pre-placing things. There are some healthcare systems that already have these ultra cold freezers. And then really making sure that the supply chain, everyone's competing for this globally like many other supplies. So we pre-purchased lots of ancillary supplies. That was another thing in 2009 that was supposed to come with the vaccine and it didn't. So it was a lesson learned that we need to plan for that and get our own just in case it doesn't come. And then the unknowns of sort of acceptance of public demand in all of these different phases is a big unknown. There's a lot of system and data reporting requirements as well. And we've invested a lot into our existing California immunization registry, into the provider ordering system, and making sure they integrate. So we're really making sure that we use this opportunity to, at a very high speed, upgrade and update our IT system so that we can fulfill all the tracking and data reporting requirements. Next slide. I think that may be it, actually. Is that the last one? I think so. Yeah, I think that's the last one. So I'll stop there. I think I'm probably over my time, actually.
Oh, it's fine. We didn't expect you were going to be giving the state announcement about the new rule. Let me ask one question about that because it's confusing. What does 15% ICU capacity mean? Our ICUs run 100%. So what's its relationship to overall cases and overall capacity versus COVID cases? How does that get calculated?
So we're looking, of course, at both. The percent of COVID that's in the ICU is a general trend we're following, but it's the percent of available beds with staffing and surge. So it is true to your point, I think, but we want that runway, right? Because the number of cases now are going to show up in the hospital in 2 to 3 weeks, and as we see this peak, so we just know that there's going to be this overload. So if we look now, if you had 15%, and you're going to get extra COVID patients in 2 to 3 weeks, we're trying to have that balance of not overshooting and then I think the healthcare systems themselves are trying to make decisions about when and what to maybe cancel its elective or not as far as the ICU capacity.
So just so I understand it, so if the trigger will be, let's say the Bay Area is one region, and when there is less than 15%, if the Bay Area has 1,000 ICU beds, when there are fewer than 150 ICU beds that are empty, it doesn't matter whether the 850 patients, there's one COVID patient or 500. It's when there's less than 150 open ICU beds in the ICUs of California, assuming there are 1,000 beds, then that triggers this much more restrictive stay-at-home order.
That's right. Given the trajectory we're on and, looking at our case rates now that George presented, we know that about 12 to 15% of the cases end up in the hospital. And then we have decreased the percent that end up in the ICU, but we just know that's our rate limiting factor with both staffing and space. Okay.
And as I understood the announcement, there are currently none of the regions are at that number yet in terms of triggering it, or is that not right?
They were literally re-updating the numbers up until right before I joined this. So I think there may be one region that's going.
I think according to the Washington Post, it said none of them yet, but it sounds like they're close. And
I think at least one is imminent then. Yeah.
Imminent. Yeah. Got it. Okay. Very good. Well, we'll turn back. We'll focus mostly on distribution when we get back to you. So let's bring on Desi to talk about how this all plays out when we get a little closer to home here in the UCSF Health system, because we're going to start getting our share of these vaccines, and we got to figure out what to do with them and whose shoulders will get a poke probably in a couple of weeks.
Thanks, Bob, for having me. Next slide, please. So as Erica stated, we are planning California-wide and specifically here at UCSF, but University of California as a whole is planning. We have a policy, and what we're doing is making sure that our policy and procedures are really the same throughout the system of University of California. So we will have our people, our patients, and our employees sign a consent, including our students. And if they decide to decline, there will be a declination form that they will sign. Next slide, please. So as you know, we will be, as everyone's heard, receiving vaccine probably in the next couple of weeks at UCSF. We were pre-positioned or pre-approved in COVID ready, which you see here on the side of the slide with the Pfizer vaccine. So on December 10th, Pfizer will be going to the FDA for EUA or emergency use authorization for their vaccine. And then the week later on the 17th, Moderna, the other vaccine, the mRNA vaccine, will be going for EUA as well. So we've got two vaccines coming out rapidly together. So we are fully enrolled at UCSF. This also includes our Benehoff Children's Hospital in Oakland. We've been collaborating very closely with the Department of Public Health, both on the state side and in San Francisco. Next slide. So here are the two mRNA vaccines that we're talking about, one the Pfizer vaccine and the other the Moderna vaccine. So side-by-side comparison, the dosing, our two doses, they're 21 and 28 days apart. They're not interchangeable. You do have to get both doses. Here are the minimum orders. The Pfizer vaccine particularly is the one that's very precarious to store and distribute. So the 975 doses come in a box that's 9 inches by 9 inches by 2 inches. So think about a pizza delivery box. And the vials are about 2 ml, so they're very small vials. Each vial contains 5 doses. It is a lyophilized powder. It is stored under deep freeze, so minus 70 degrees Celsius. And it needs to be reconstituted. Obviously, it needs to be taken out of the freezer, defrosted. Usually, it could be defrosted either at room temperature, but usually under refrigeration, and then transported to where the patients or employees will be vaccinated. So in the last few weeks, I've learned more. They don't teach you this in school about dry ice pellets. So these sort of pizza boxes there'll be 5 of them in a shipper container, and that shipper container will have about 23 kilos of dry ice in the pellet form. And you can actually use dry ice and keep the vaccine cold if you don't have a minus 70 degree freezer. We have many of those. We have capacity here at UCSF right now with more to go to store way over 500,000 doses. And that's just on the San Francisco cabinet with more campus, more storage freezers on the Oakland side. So you could see there is also some short-term issues. So with the Pfizer vaccine in the fridge, it's good for 5 days. At room temperature, it's only good for 6 hours. So again, a lot of talk on the storage here. You can see Moderna, it's refrigerated for 30 days and in a minus 20 freezer, less cool, for up to 6 months. Next slide, please. So this came from the San Francisco Department of Public Health. I really, really like this depiction because it tells you where, now this says, and this was a few weeks ago, that California was anticipated to receive 1 million doses. We know, as Erica stated, it's probably in the 300,000 range. But the federal government will be supplying the groups listed here. So the VA, the Department of Defense, the federal prisons, the Indian Health Service, those doses will come directly from the federal government. And then once we get to the 1B phase, the government has signed contracts with Walgreens and CVS and Walgreens will be working with skilled nursing, residential care, long-term care facilities, and any staff that wasn't vaccinated in the 1A group. And then, as Erica stated, a lot of work on the state side with all the groups. So state prisons, state hospitals, then multi-county entities. And that definition is greater or equal to 3 counties. So again, right now, San Francisco is sort of not in this group, but other counties throughout the Bay Area may be. So, for example, Kaiser will have multiple counties, places in Fresno and Sacramento, and so on. One thing, I already stated was we are including all of UCSF, both on the campus side, the students, the learners, the trainees, and on the Oakland side. And we are working on a process for our affiliates. We may have a role with other health systems being a early participant if we're asked to vaccinate healthcare workers, first responders, and others that don't work here, aren't patients of ours, and we are going to accommodate all that are at high risk and in need. Next slide, please. So this slide you may have seen before from the National Academies, Academy of Medicine. And again, we're right now in the middle of this phase 1 start here, which is high-risk healthcare workers and first responders. Next slide, please. You just saw this slide from Erica. Again, we're working on this first part, which is 1A. Next slide. So the definition of a healthcare worker is listed here. What we've done here at UCSF is look at 1A, and we've actually divided 1A, and I'll talk about this in the next slide, into 4 groups. But we're, as I said, outside of the health department, we're really involved in UC in total, and also working with San Francisco General Hospital as well. We've got working groups, and I'll show you that diagram shortly. We're really looking, and I think Erica touched on this, equity and ethics. And again, our review is pretty much done. Our draft is done. We're having others from senior leadership look at the draft, and hopefully it'll be ready to go by the end of this week. And I'm using a rolling week, so Sunday the 6th. Next slide, please. So here are our 4 groups, and really these are all just from all the data from ACIP and Departments of Public Health and all of the evidence. So our highest risk group are frontline, patient-facing clinical staff, close, prolonged, repeated exposure, at risk, close contact with patients of unknown COVID status. So that's our group 1, and then you could see it cascades to group 2, 3, and 4. And so, for example, on the right hand of the slide, you'll see the UC Police Department, their first responders, they are in this group. So there are some non-healthcare workers in this group. We have research teams here at UCSF that are actively manipulating and working with COVID-19 in the lab. They will be in this group. Anyone that's training, a clinical student, a fellow, a resident, people that will be vaccinating our employees and our patients, they all will be in this group. Many who work with aerosolizing procedures, respiratory therapists, they will be in this group. And you probably think group 1 will probably be people in urgent care, emergency department. It's not just the nurse, the doctor, it is the transporter, it's the housekeeper, it could be the phlebotomist, it could be, of course, the respiratory therapist, the radiology technician, anybody that would be in this definition. So again, we are looking at equity as well. Next slide, please. So here's our task force structure. We've had this steering committee for about a month now. And then we obviously have all of this in progress. As you can see, we're ready to receive vaccine. Security of vaccine is extremely important, as well as storage. And of course, manipulating the Pfizer vaccine, as I said earlier. Our prioritization is about complete. We're starting to work on 1B and 2 prioritization of patients. And then we've got groups deployed for operations, both for employee vaccination and patient vaccination. And again, we have done this very successfully with flu vaccine, and all of those folks that work in population health and occupational health and infectious diseases. And again, our media and communications team, our IT team for data, and our quality team for data, and having everything documented is also very involved here. So with that, I will stop. Thank you.
Great, thank you, Desi. And let's go ahead and bring back Erica and George if we can. Desi, I could see the interest in vaccines so high, there was already somebody banging on your door to try to get in.
Yeah, I'm in the hospital, so I don't know what they're doing out in the hallway.
I think they want vaccine. So, all right, I'm on the wards in the end of December. So I'm probably in group 2 because probably won't be taking care, group 2 of group 1, the second or third. Is somebody going to send me a note saying I'm eligible, or do I go and they tell me there whether I'm eligible? How is that all going to actually work?
Yeah, so we're in the middle of getting that ready. Again, Bob Kosnick, who is sort of the guru on operationalizing, he's our physician in occupational health, along with Gina Interelli, who runs our POP Health division, are getting all of those ready. Got a preview yesterday of some of the really slick technology available. So we're looking at technology that you would be able to have an appointment, or you could schedule something. So it's going to be a push out and obviously a pull. So you're able to also get your second appointment.
But much of it will be you telling people that is their group is up?
Correct. We're hoping that.
Yeah, and how are you going to deal with the fact that some people feel pretty crummy after the vaccine? They may decide they can't work. They may have symptoms that resemble those of COVID. Do they get tested? How is that all going to work?
So that's a really good point that I should have brought up. So thanks for reminding me. So we are going to, for our staff, stagger probably in 25 to 30% increments. So we don't have all the nurses or all the hospitalists out at a certain point, because there is fatigue and headache and fever and other things that people may be out for a day if they do have, if they're in that small group that experience side effects.
And George or Erica, so how are we going to deal with the fact that now I've gotten my shot 3 days ago and I have a fever? Do I need a COVID test, or I'm okay just saying it's from my shot?
I'd just say it's okay if it's from your shot. I mean, these things happen. Right?
So we're going to assume that up to a given number of days that it's from your shot. But
understand that there's an infection risk standing in line with all your best friends, with your 500 newest best friends.
Yeah.
So, that's the complicated part of this that we didn't have to deal with swine flu and, some of the other things, is that, the infection control issues are not insubstantial.
Yeah. Erica, how are we going to convince people to take this? I assume there'll be a pretty big demand in the beginning and it will exceed supply, but then those curves could reverse. And we didn't get it right on masks in terms of sort of convincing people to do something that was easier in a way. So what are the strategies? How are you using Instagram and TikTok and influencers and all that? Because it's probably not just health people telling folks. It's a broader campaign.
Yeah, no, thank you. That's definitely our biggest concern, right? If we could get all the logistics right, but if nobody wants it, and I think, we've also been very clear, we are not mandating, certainly from, we want people to want this vaccine and feel comfortable with it. And that's why, again, we have these extra sort of layers just to make sure that we also feel comfortable that it's safe and effective. So we have a huge sort of communications team, a lead that's dedicated to just the communications. They're doing some research and focus groups actually with healthcare workers now, because we knew that healthcare workers were going to be the highest priority, and then starting to branch out beyond that to also do sort of research and focus groups. And actually we had a great call just this week with I think the network is called Stop COVID-19, but actually also a UC network of research looking at vaccine acceptance and actually enrollment in vaccine trials for communities of color. So Dr. Arlene Brown is leading that and is also on our drafting guidelines work group. And I think really taking lessons learned from her work or that network's work, and our community advisory committee is what we're also really hoping by working closely with that committee, making sure they are seeing everything as we are, learning kind of, how we're making these decisions, seeing the safety and efficacy data, that they can also help us sort of get the message out to people. Because I think to your point, a couple of things, right? Like I know for sure people are tired of hearing from public health officials and sort of from the government, right? I think there's a lot to be said for trusted messengers. And I also know that certainly a lot of people are really interested in the science, but there's plenty of people that the science has nothing to do with it. So we really need to work with faith-based communities, other community leaders to really get our message out.
Desi, are we going to require this of UCSF employees to actually take the vaccine, or what happens if they don't?
So we're not making it a requirement. If people don't want to take the vaccine, they could decline. We will probably, if they decide and change their mind, we'll obviously address that as well. But we're not making it, the University of California in total is not making it a requirement.
Why not?
Well, that's a really good question. Maybe Erica could answer that, or George.
George, why not?
We did it for influenza.
Yeah.
Right? It was President Drake said everybody had to get the influenza vaccine. It got beaten back in courts. So.
Yeah, I think this is a first. It's a little bit different. I think this is the first year that the University of California said it was mandatory for flu. I know in other parts of the country it was mandatory years ago, depending on where you were. But I think at this point, this is new. This was quick. And we're taking, I think, a very conservative approach. I think it could change.
Yeah. Erica, we'll go another 4 or 5 minutes if people could stay. As I understand it, the CDC puts out its recommendations in terms of the priority list. The state does not have to accept it. Is there a chance that we're going to reshuffle that deck? And then when we get, there's certain categories that I'm trying to figure out how they get adjudicated. Is it the state level or local level? Like, how do you prove that you're an essential worker? What are the diseases that put you on the list of a pre-existing condition? And how does that get proven when you show up at the Walgreens or show up at UCSF Health? Is that you guys going to do that, or we're going to do that? Where does that all happen?
So it's multi-layered, like everything else. So that is exactly what the drafting guidelines work group is doing now. And it's great because our teams have pulled together data, again, just using the first example first, because that's where the most work has already gone into, thinking about all the different kinds of healthcare workers, what are the different settings, and also making sure that, healthcare worker actually includes all the important custodial environmental staff, other people that have any, direct patient interaction as well. So that's also then going to happen for essential workers. So at each layer, I think, so for example, again, the drafting guidelines work group has worked out, on a state level, how to sort of prioritize and some criteria for each of those. And then at the local level, they kind of need to do that again. Like if you have, in San Francisco, you have X number of ICU physicians, ICU nurses, and sort of, and Desi really kind of outlined really well within UCSF how that's going to happen. So each county will have allocations based on these guidelines, but they'll have to actually figure out the actual numbers. And then similarly at each system, like at UCSF, there will be these decisions made about that.
I'm not as worried about, I figure UCSF can sort out whether I'm in the ICU or not. I'm sort of at the next layer when we get to the patients and they have to prove that they have a pre-existing condition. Note from your doctor when you go into Walgreens, and is there a list somewhere of the pre-existing conditions? And then the essential workers, do I have to prove I'm a teacher or a firefighter, and how do I do that? And this just seems like a lot of devil in the details here.
Yeah. I mean, I think a lot of that will happen both either at the employer and or local health department level. And I think, I will also say, there's a lot of other logistics too around, Desi was talking about these shipments that come in 975 doses. And in some of our more rural communities, we know, and there's some principles again about trying to stick with the framework, but you don't want to waste vaccine either, right? This is a really valuable resource. So I think there, and I think less, but I think there was a lot of sort of honor system in 2009 as well, as far as which county you were in. And but I think a lot of the distribution again will be initially through people who already vaccinate. So the pharmacy chains are really focusing on the long-term care facilities. That's what this federal agreement has been, and a lot still needs to be worked out there too. But a lot of this will be by provider who should already know. And I think there probably is going to be, it's just like a lot of our other public health guidances. I think we are not, a place where we're necessarily going to have to check every detail or have proof like that.
Yeah. I guess a lot of it depends on the band. So let's take last minute and go round the clock and just what keeps you up at night? Desi, other than the banging on your door, what keeps you up at night?
Oh, every morning I wake up and say, I can't believe I'm in a pandemic, right? I would hope that we would hear soon about how much is getting allocated so we could plan, because we're planning for a little bit of vaccine. That's why the 4 groups, or a lot, where we can really have our, entire workforce, our students, our campus employees. So that's one thing that keeps me up at night.
Yeah. Maybe before you answer, Erica, we hear the 300,000 doses or something to California, and then we hear there'll be enough vaccine by the end of the year at the national level to vaccinate 20 million people, and California is 11% of the US population. So I've got a little bit of a disconnect there I don't understand. Can you clear that up?
So I think, so there will be shipments every 2 to 3 weeks is our understanding. And then of course, as each vaccine gets approved, there's different numbers, but let me just see if I have that on one of these as well. I think our understanding by the end of the year is more like 1 million total.
So it's just that initial thing is the 300.
Yeah. Okay. Yeah. The initial 300 and then another 700,000 over the next few weeks.
That gets closer. What keeps you up at night, Erica?
I think what we talked about, acceptance, right? I think, it keeps me up at night that if we don't have acceptance of this and we can't get enough people vaccinated, then that would be,
Yeah. George, what keeps you up at night?
I'm with Erica, 40% vaccine coverage, or is this in the exact same place this time next year?
And is that your prediction or that's your worry?
That's my worry. My prediction is 60%.
60%. Yeah.
And to George's point, the surveys right now are at about 50%, I think, right? Of if you survey people, only about half are saying they'll take it.
The latest was 60. And I keep saying I don't believe it because, in a vacuum, it's one thing. But now that there's, vaccines with 95% efficacy and you're going to start seeing Fauci get his shot. And this is not about a childhood disease you've never seen. It's about a disease that's in the news every single day. It just feels like it's not going to be 60, but maybe I'm wrong. George, tell me, you think that is going to be 60%?
If you have to guess a number with a 0 at the end of it, yeah, I would guess 60%.
Well, that'll keep us up at night because that doesn't get us to where we need to get to.
It may.
Yeah. I mean, because
then exactly where herd immunity is.
Yeah, it's 60% plus.
But what difference?
It's 60% plus some people have immunity from COVID as well.
Yeah.
To get us there. Okay, well, thank you all for the work you're doing and for your partnership. And these are hard jobs to make all this work. But as we fret about them, it's also worth remembering that it's a good problem to be fretting over. We didn't know a month ago that we'd be in this position. So hopefully it will roll out as well as it can roll out, and we'll be in a better place in a month or two. And Erica, thanks for your leadership and navigating through the complex politics of all this. As I read the announcement and hear what you say, it does feel like we got to be pretty aggressive about taking this really seriously because we do not want to be overwhelmed. It's terrible. So thank you. All right, let us quit.
Yeah, well, thank you.
Yeah, thanks so much. And thanks for joining us. Here's our crack production team as usual. Put this on. We'll have it on YouTube tonight at about 7 or 7:30. And next week is a regular medical grand rounds. We'll be back with another COVID edition in 2 weeks on the 17th. Until then, please stay safe. Thanks so much.